Good evening, everyone. Welcome to the IR webinar series conducted by ICMR and in association with IISc Bangalore. So today we are in our seventh session of the webinar. I'm Dr. Kavita Dhanashekharan, Scientist E from ICMR headquarters. We like to invite Dr. Prashanth to take us through the session for today. Today's topic will be on the frameworks with with the tinge of the real world examples. And little bit about Dr. Prashant before we start. He's the director of Indian Institute of Public Health, Bangalore. He is a medical doctor working in public health, and his area of focus is implementation research, health policies, and system research. And he also focus on Adivasi health, social inequalities, and health, and community mental health. And he is also board member of editorial board for health policy and planning, and also PLOS Global Public Health. So welcome, Dr. Prashant, and thank you so much for being here today with us. And without any further ado, I request you to proceed with the your didactics. And I also request our participants to keep posting the questions in the chat and in the Q&A session. Please, the stage is yours, sir.
Thank you. Thank you so much, Dr. Kavitha and the backend team at ICMR National Institute of Epidemiology and to the Center for Public Health at IISc and ICMR HQ for putting together this webinar series on implementation research. Just very one minor correction. I am not the director of the Indian Institute of Public Health, which is a completely different institute. I work at the Institute of Public Health in Bangalore. So with that,
Sorry for
if
that.
no problem, no problem. It's a very common instinct. Okay, so please can you confirm, Dr. Kavita, that my screen is visible?
Yes, sir. It's visible,
Thank you.
sir. Visible. Yeah.
Thank you. So thank you once again. And so this is part of a series of webinars that the ICMR and the IISc Center for Public Health have put together. And for those of you who have not been part of the previous series, I webinars as well, which are available in a YouTube playlist created for putting together this series of kind of lectures and interactions on IR. So in this webinar today, we are talking about the use of theories and frameworks in implementation research. This is very often considered very confusing. It is considered something which is very difficult, challenging, and often I've heard many public health practitioners who take strong views on should there be theories or frameworks at all. Many of them, I've heard many colleagues feel like they are also applied in a way that that is not very scientifically robust, etc. So we'll try to discuss many of these aspects. We will try to do so using some examples which I have put together in this presentation. The way I've tried to structure today's talk, and I will try to finish it in about half an hour to 45 minutes max. And after that, we can certainly try to have some interaction. And I will try my best to either answer, and wherever I do not have the answer, to point you towards resources that might be helpful to respond to some of the queries. So the structure I'm roughly going to follow is I'll start with a little bit of background to why we need to really think of theories and frameworks at all in the course of IR. Why can't IR be done merely by collecting data on implementation, good quality data, analyzing it just like we would do for any survey-based method or any pure qualitative method, etc. Clarity on words that are often used sometimes interchangeably. Theory, framework, model, and those kind of terminologies. We'll try to look at some kind of examples of how frameworks slash theories have been practiced in IR published IR research, and we will also look a little bit at limitations of the use or application of some of the key frameworks that are often talked about. Um, so to set the stage for the use of frameworks, theories, etc., I would bring your attention to the four bullets on the left-hand side of this slide. Very often, many of us who are engaged in implementation research, we are trying to enter into a system. Now, what could be a system? A system could be a primary health center system. So a network of primary health centers in a district or a state. It could be a hospital system. For example, if your intervention is focusing on block level or taluka hospitals, and you want to create a new kind of a intervention, or it could be anything. It could be among ANMs, for example, so sub centers or health and wellness centers. So many of these human social systems are what we call as history dependent, path dependent. Many of them are used to a certain way of work, which our interventions tend to want to change or disrupt in some sense. So these are what we call real world settings, as opposed to what are more controlled settings. For example, if you if you are designing a randomized control trial, and even if you are implementing it across a large geography, the control over the various elements or components of their intervention is much higher. Whereas implementation research, such as the kind of IR promoted by ICMR, promoted by many of the participating institutions, seek to bring change within primary health centers, within district hospitals, taluk hospitals, or various practice settings in real world. And many of these cannot be controlled merely for the sake of experiment, right? So many of these places have a deeply entrenched sense of how they would like to function. So when interventions try to change them, very often interventions face resistance to change. Yeah, not because people don't want to change, but because the purpose of the intervention, the intentions behind it, the various reasons why these interventions are taken up are not obviously shared by such a large number of people. So over time, interventions need to engage with what we call in systems thinking as path dependence. Yeah. So keep that thought for one. So the fact that healthcare organizations are social organizations, they have people who have their own conceptualization of their work culture, and whether they wish to change the way they are working or not. Second, change within many of these systems that we are talking about. Let's say, take for example, we want to make a change in the way hypertension is treated within primary health center network across a state or across several districts. Change at the primary healthcare system will require change at multiple levels. And you can look at that change within individuals. It could be within organizations. It could be within family or teams. For example, if a PHC's quality of care for any condition, say hypertension, has to change, merely giving training to the doctor or the nurse alone will not be sufficient, because the entire team within the primary health center will have to change the way in which it has been organizing care for hypertension. So family, or in the context of healthcare organizations, you can look at teams. A third layer, institutions. So the relationship between the primary health center and the THO or the taluka or block level office, with the district health office and the various other program managers, the nature of those relationships, whether the higher officers are also bought into this new kind of way of work at the primary health center, that also affects change. So that's the third level, institution. You can look at community. So what if we are able to excellently train primary health center staff for hypertension care, but communities do not feel the need to go periodically to their PHCs, get checked. What if the felt need for this high quality treatment for hypertension does not exist? And finally, at a much larger level within society itself, what if it is a health problem for which you have an excellent solution, but social norms do not allow them to engage with your solution? For example, stigmatizing conditions, let's say sickle cell disease, or care for self-harm. So I have a family member who has recently attempted self-harm, or he's showing risk of self-harm, but various social norms does not allow me to take my family member to a health worker or a PHC. The PHC may be extremely well trained and may have all the right attitudes to respond to the situation, but that does not prevent the implementation effectiveness of that training. So I think many of you are probably extremely well aware of these. That's the reason why we consider IR in real world settings to be affected by so many different levels within so many different individuals, teams, institutions, communities, and society. And finally, the fact that health systems or health services change requires to engage with things that we tend to not technicalize, which is interests. And by interest, I'm not only talking of interest in the program, but what are the various interests of individuals and various institutions in that unit or system which we are seeking to change? What is the stake people feel in the new program that is coming? What kind of norms exist within these institutions, and how will they interact with the program? And what are the probable unintended consequences of the kind of interventions you take up? Many of these require this kind of systems thinking, this kind of big picture thinking that we say, because we cannot achieve change in real world settings merely by having the technical details of what program we want to do correctly. And the reason for that is that health systems are social systems. They are made up of people. They're made up of people's ideas, interests, norms, values, and how they interact with each other. So given that these are all social interventions, reducing everything to say context, which is very often used in public health, right? Loosely to explain that here is my excellent intervention, and now everything else is context. And I will study the context while implementing my excellent intervention, does not represent a good way of using our insights into how societies work and try to use that insight in adapting or delivering our intervention. So that very broadly, that is the role for theory in rolling out implementation research or in rolling out interventions. How do we use insights of how societies have organized themselves, and what is the study of how societies work? Broadly, these are coming to us from the various social sciences. And by the social sciences, we are talking of a very large number of individual disciplines ranging from sociology, psychology, organizational sciences, anthropology, economics, etc. So the idea is not that we shall all try to train ourselves to become all of these disciplines, but the idea really is to understand that various disciplines are already advancing our knowledge of how societies, how people work within institutions, how organizations can improve their work culture, etc., which we need to borrow, read, and bring into practice within healthcare organizations. So with that clear, another background element I wanted to introduce here is how we as IR practitioners or public health practitioners ourselves view health systems. And I'm sure many of you are familiar with the WHO building blocks framework, for example, the most popular one. There is another framework called looking at health systems as control knobs. So where you try to change some of the inputs and then you try to see whether the desirable outputs come. There is another one called the health systems dynamics framework. So those frameworks, but the purpose of this slide is to share that frameworks are also somehow reflecting um, a certain understanding of what is a health system by the people who advance those frameworks. So Josephine Van Olmen and others have this very interesting debate paper in BMC Public Health, which I really like, where they say health systems frameworks in their political context, framing divergent agendas. So when we say there is a certain framework that we can use in our IR or in, for that matter, any public health work, we should also try to understand what is the kind of worldview from which a certain framework comes. Similarly, we ourselves might be conceptualizing health systems in certain ways, which tends to actually influence our practice. Obviously, here, political context does not mean electoral politics. We are here talking about the nature of change that we conceptualize as individuals or institutions. How do we engage with people and agenda setting and advancing a certain idea across actors and institutions. So health systems, if the moment you look at health systems as social systems, the moment you look at health systems not as mere pipelines to deliver medicines, but as places where people, both communities and health workers and governments, come together to try and organize an essential function for the country, you start realizing that um, many more things outside of the medical and technical and clinical details that we often take into account will also matter. So the purpose of this slide is to make all of us aware that frameworks reflect have conceptualized the phenomenon that we are studying. Many of us may feel that we, if we do not use a framework, then we are actually free of any such kind of an agenda. And a lot of social scientists tell us that this is not true. To give you an example, um, if we say quality of care, let's say I want to study quality of care for quality of care of um, say diabetes at a primary health center level. One way is to immediately use a quality of care checklist or a tool that is prepared by, let's say, the WHO or some standard entity. And then we just use that tool and apply it in all the PHCs in our district, and we analyze and we say, okay, this is the way quality of care. Another way is to say, okay, this tool, how does it, what does it include as quality of care? Yeah. So, for example, does the tool take into account how empowering the care consultation was for a diabetes patient in terms of advancing his or her self-care, right? So there may be quality of care for diabetes tools out there that do not actually consider this, right? So what a framework would do in this context is, framework would a quality of care framework would help you to say what are all the different elements that I should take into account if I'm interested in measuring quality of care in my primary health center. So it helps you ensure that you're not missing several components of which have a bearing on quality. In this instance, the sense of empowerment a patient feels through a series of diabetes care consultations comes from a people-oriented kind of a person-centered care approach. So a person-centered care approach means that care is not only technically appropriate, but the care is also perceived as and actually improves a sense of dignity or empowerment or that kind of a healthcare experience for patients. So consciously or unconsciously, all of us actually view the change agendas that we bring into implementation research in a certain way. What theories and frameworks kind of thinking pushes us is to try and make it more explicit, either through borrowing a popular framework that is out there in literature, or leveraging or thinking carefully and conceptualizing our own framework of how we have thought of that change agenda. Um, um, Here is an example, colleagues. My colleague Upendra from IPH, Deva, and others, in the context of organizing diabetes care in an urban poor neighborhood in Bangalore, for example, used what is called the health systems dynamics framework. Now, the purpose is not to say that the health systems dynamics framework is an amazing one and each one of you should use it. They used it because they were interested in how governance, resources, service delivery, population, and outcomes are linked in a specific context of an urban poor neighborhood in achieving goals for diabetes. They were also interested in what kind of values or principles seem to emerge from the way in which healthcare services are organized in that neighborhood. Why did they do this? At the time, they wanted to use this as a formative research in order to better understand the diabetes care ecosystem in an urban poor neighborhood. Because their assumption was, if we understand this better, then we can perhaps design interventions that will better cater to these. So this is, for example, one of the ways in which they have conceptualized an urban poor neighborhood health system, try to understand how the system operates before trying to move towards design of interventions. Another very popular thing, this was covered in a PLOS Medicine series that many health policy and systems research scholars were involved in over a decade ago, is the idea that health systems have what we call hardware elements. I would like to focus on the circle in the center on the right side of this slide, where the idea that health systems have a lot of hardware elements, which basically are the WHO building blocks. But what makes these hardware work is what the proponents of this framework called software. The fact that relationships between actors, the power dynamics between actors, values, social norms, etc., are the kind of intangible, I would say allegedly intangible. They're quite tangible actually if we look for them and study them. But these, how these software elements interact with human resources, finance, medicines, the organizational structure, etc., to actually result in what we look at as a health system. To give you an example, it was one of my colleagues who was studying what makes better integration of care for non-communicable diseases at primary health centers. Quite unsurprisingly, found that primary health centers, doctors are able to have a certain style of leadership which brings the staff together. So doctors who are able to, PHC medical officers who are able to take the staff together in the change agenda are able to rapidly implement new interventions or new resources that the intervention gives and realize the impact of their interventions within their PHCs. So in this case, what this framework helps us explain is the fact that the the leadership style of the PHC MO is a system software element which helps the primary health center to benefit from a new diabetes or NCD program that the state or NGOs or academia brought into their PHC. So the moment you start becoming aware of these software elements through reading this kind of frameworks or looking at literature of this kind, they offer you a certain lens through which you can try and explain the kind of change that you see in some PHCs and the kind of change that you may not be seeing in some PHCs. So in some sense, these frameworks are, if used properly and critically, can offer an explanatory lens through which to examine your quantitative patterns or your data that you're gathering in your IR. And on the left side, you will see are highlighted, where they try to show that working with this so-called intangible concepts like power, ideas, interests, relationships, values, norms, things which we just conveniently take away, say, oh, these are contextual elements, or oh, they are outside the control of researcher, is that notion is challenged by offering some examples of how various interventions in India have tried to engage with this kind of a systems software elements. So basically, the purpose here is to challenge our notions that not to put everything outside of the intervention into a large basket called context, which is a black box, but rather conceptualize the relationship between the intervention and the setting, and already try to anticipate and foresee what are all the possible ways in which the intervention and the setting will react, and how can we explain or adapt the intervention to be better fit to the setting where it is happening. Um, the last slide, I think, in the background is this the latest MRC Medical Research Council guidance, which also I've highlighted on the right side a portion which I found very useful, where they urge that especially for decision maker oriented research, which is basically what IR is. Like, for example, if the question is, how do we deliver care for self-harm in large emergency medicine, emergency or casualties in large district hospitals across the state? Now, that's a very complex challenge. Decision makers and health departments are facing these challenges, and they want academia to try and urgently engage with these. And there is no time to, for example, have a large RCT to be able to do this sometimes. So sometimes we will have to work with decision makers, design, look at what evidence based exists, design a and then come out with a better model that we can provide to decision makers. So for many of these kind of approaches, what the MRC guidance also pushes us to do is represented in this summary points, and especially I think what they urge is the second one in the 6 core elements that they say. They ask us to first understand what is the underpinning program theory. What is the theory that explains how a program is expected to work? And we'll keep this in mind for those for whom this is not very clear. I'll try to clarify theory as we move along. So, moving to the second part on the definitions, this is a paper that I really liked. This is from BMJ Global Health, which helps us understand how to. It's a kind of a practice. What are really the different ways in which implementation science theories and frameworks have been applied in global health? Of course, global health is a very contested kind of a thing. The way and different people understand different things when we say global health. For me, this is basically public health, which is communicated to a very large audience outside of small geographies. So in some sense, what we are all doing can also potentially be claimed as global health, although invariably it's high income country scholars who are calling what they do as global health, as if what we do is local health. So in some sense, what we are discussing today is also global health. And this is the framing paper, which I found very useful to be able to understand why we use theories. And the key thing is in the bottom part of the right side, where I read out, in social science, theories explain rather than describe the causal relationships between a phenomenon and an outcome. Along with conceptual frameworks, they are used to guide the research process, especially for analysis and interpretation. And this too, I think, is good to note down, because some of us use frameworks that are better fit for describing a situation. Like, for example, the framework that I showed earlier, where somebody used, my colleague Supendra and co used health systems dynamics framework to describe the urban health ecosystem for diabetes, whereas many conceptual frameworks are designed for analyzing a given situation. And the frameworks for these are all very different, and it's useful to for us to be aware of what kind of a framework we are using, something that we will cover. So, a frequently confused kind of or interchangeably used words are things like models, frameworks, and theories. So, models are fairly narrow in scope. Basically, models um, uh, are are visually schematic kind of approaches, like for example a logic model, yeah, or implementation model for a diabetes integrated diabetes care program. So these are schematics. They do not have too much of context in them. They are typically derived from lot of empirical work, and they are usually very specific for a given problem or a given setting. Frameworks are a little bit above models. They tend to try and provide an explanation of a given phenomenon. So, for example, there is the CFIR framework, which is often CFIR, which is often used. That's an example of a framework because it helps give a mapping of all the aspects that have to be taken into account while designing an intervention. And above models and frameworks are theories. Theories are somewhere at the level of explanation of why social phenomena occur at a much higher scale, and they are expected to have more power uh, to explain a certain phenomenon than frameworks or models. We'll look at some examples to be clarifying this, and in the slide itself you have some of the references which you can read up. So here, program theory is very much similar to what we call intervention theory. So, program theories or intervention theories are very close to a given program. For example, a theory of change is often used. Theory of change is an example of an intervention theory or a program theory. Many people prefer to write their program theory in words. To give you an example, in and a well-written program theory is basically a hypothesis of how the the designers of that program expect their intervention to work in a given setting, right? And often you will not find this well written. For example, if there is a if you take a specific intervention that has been implemented at scale, you may ask, okay, where is the theory written? These are not often written. So often qualitative research will need to be undertaken to actually prepare what is the intervention implemented. You contrast program theory to what we call a middle range theory. Middle range theories are theories a little bit at a higher level. They are at the level of human agency or institutions. For example, theories on motivation. What motivates people, and this is something that can have an explanatory power across large countries or across even human societies. Between these is a framework. A framework is some kind of a structure or an outline of all of the key processes, phenomena that ought to be taken into account in order to explain a given phenomena. For example, again, if I take the CFIR framework or the re-aim framework, many of you may be familiar with that. This is a kind of a schematic that says, okay, in case you have an intervention, please ensure that A, B, C, D, E are all known to you, because A is connected to B in this way, because B leads to C and C to D. So it's a way in which people who have studied implementation or interventions across many settings are finding a common pattern. So in some sense, frameworks for me represent wisdom gathered from practitioners and applied in a scientific way. So you can take this kind of wisdom, systematize it, and use it from one setting to another. Grand theories, of course, are at a very high level. They explain everything about human behavior Psychologists typically have some of these grand theories, theories of cognitive dissonance, or things like that, may not be fully relevant to our conversation here. So let's quickly look at some of the kind of frameworks. This, for example, is one way to represent the CFIR framework. What you see is a framework that helps you, that first tells you that change is at multiple levels. Yeah, something we covered. It looks, and then it tells you the fact that there are various ways in which change can be conceptualized at individual level with its own barriers and facilitators. Then it urges you to organize uh, at two different levels contextual elements, what they call the inner setting. So within the immediate workplace, within the family, within the immediate social environment of the individual, but a large outer setting, things at a macro level, policy level, macroeconomic level, for example, etc. To give you a very quick example, if you're looking at implementation of dengue interventions in the context of a city, the fact or vector-borne disease control program, things like climate change or a rapid change in policies related to vector-borne diseases, etc., are things that are happening at an outer level but have an impact on your intervention. What if, to give you an example, let's say you've been working on sickle cell disease for a couple of in 2015 or 16, when it was relatively neglected disease. Suddenly, by 2020, 21, 22, it became high on the policy agenda. So those few of us who were working on sickle cell disease suddenly got a rush of interest and energy from the outer setting, which was aligned with our interest even from before. So these are ways in which interventions can be influenced from far away macro drivers, but can also be influenced by inner drivers. So this way, frameworks like CFIR help you organize, explain, plan, manage your IR project. Yeah, so that's why I've highlighted this. So the CFIR, for example, is a framework. What we looked earlier at health systems dynamics, where various building blocks of the health system were shown through arrows in a certain way, is a way of showing how different building blocks are interacting with each other. And so it offers a potential explanatory power to you to use in your specific setting. Another example where some of us from IPH try to understand what makes um, someone at the district or taluka level who receives training in organizational change or improving their district or taluka through better planning, what makes such kind of programs work, right? I mean, it's a bit naive to imagine that people who receive training will automatically be able to go and realize the effects of their training, because as we saw, we are not talking of mere change in individuals translating into systems change, right? It's quite possible that you can have a highly well-trained primary health center where knowledge of everyone has improved, but the primary health center itself is non-performing, right? These are things that many of us might have seen. That's because in complex human social systems, merely individuals' knowledge improvements may or may not translate into change at systems level, at institution level. So in this kind of a context, what I used, I won't go into the details of realist inquiry, but what we used is what we call a intervention theory. So the approach was, you first try to understand what is really the underlying theory that explains the intervention, the capacity building intervention that IPH and other stakeholders were doing in Tumkur district in Karnataka. First, carefully describe that program theory or intervention theory, and then in an iterative manner through contrasting case studies, you test. You don't merely confirm, because that would not be science. It would just be something that we end up with a confirmation bias, but you adjudicate, you validate through purposively, contrastingly selecting cases which are counterintuitive to each other. So what about talukas where you see positive change in response to the intervention, And you contrast that with talukas which received the intervention, people's knowledge improved, but things did not change. So why was there a difference? You try to carefully adjudicate between these purposively chosen cases and try to explain how organizational change occurs in response to individuals who get trained. So that is a process that is available in some of the papers in this slide. Another example of the use of this kind of theory, which we call program theory or intervention theory, is my colleague Pragati and others who worked on trying to understand how does change occur in the tobacco control policies and programs that are being introduced for the last decade across the country. And very clearly and unsurprisingly, all of the country will not always uniformly show a response. You will have some districts, talukas, villages, cities, or states which do very well, some others which don't do very well, not often for the same reasons. You might have two states which perform poorly for very different reasons. So here the outcome is same, but the process may be different. You might have two states which did phenomenally well, but again, the process that led to it may be different. So what you do is you build an initial theory of what probably explains good performance, and you try through adjudicating cases to try and contrast and better understand how this change occurred. So this is a process of what we call theorizing. And theorizing requires an initial program theory to be built and carefully and critically assessed and refined to form a refined program theory. So, yeah. So once again, I emphasize the difference between program theories, which are very close to a specific program or a policy, versus more grand theories or middle range theories, which are at the level of human societies and institutions. That's what we call a middle range theory, something that's at a much higher level. So to sum it all up, what you have is different types of frameworks which have very different purposes. So if you see, for example, frameworks that are what are called as determinant frameworks. I mean, this is one way to classify frameworks. Huh? So you can have frameworks that are trying to help you describe the various things that you have to keep in mind when you design interventions, because they are deterministic of how well the interventions perform. Those things like, for example, the health systems dynamics framework, etc., are those kind of frameworks. You can also have process frameworks, which are much more on explaining change. Things like program theory building, case study building, these are all process frameworks, realist evaluation guided frameworks, etc. You can also have frameworks that guide identification of outcomes that can be used to assess implementation efforts. So these are more frameworks that are of an evaluative nature. Often, I think some of the confusion in the use of frameworks comes from misapplying a framework to the process. For example, if you want to evaluate outcomes of given intervention, CFIR will not be the right framework, because that's not a framework that helps you evaluate change. What it helps you is to plan or to examine critically the process through which change has occurred. It helps you to explain some of this. Program theory based iterative frameworks, again, are process frameworks which can be helpful to help you explain this kind of a change. Theory of change, some things that many of you might have heard of, is again an example of a framework that can be used to try and explain, hypothesize a process for change and see whether that change is occurring or not. Another way to look at the different methods that we saw today is this table from the same paper, where you have approaches in IR that look more at fidelity or even acceptability, adoption, appropriateness, these kind of implementation outcomes. You have implementation studies that look at process, like what I was explaining. How do you explain change in response to a capacity building program? And you can also have theory building kind of approaches which look at in a large number of settings how change is occurring, which aim to build some kind of a grand theory or a middle range theory of how to explain change across multiple contexts. So you'll have to choose your framework based on what is the specific IR issue that you are doing. For example, if you're looking at fidelity assessment or if you're looking at feasibility of a specific intervention, you might want to use a conceptual framework that is helping you explain a phenomenon at that level. For example, if I'm looking at feasibility of an addiction program among Adivasi communities, I might have to go towards frameworks around cultural safety, frameworks that look at cultural appropriateness of care, etc. On the other hand, if I'm looking at coverage of, let's say, maternal care or something around, or let's say if I'm looking at dropouts of people from TB program, you might want to look at frameworks that try to explain why people stay and drop out of program, something that covers both supply and demand side kind of things. So frameworks work if you choose the fit for the purpose that you are working. So I promised to finish by 6:45. So this is my summary slide, and which is that theories and frameworks are useful only if critically used. They should not be uncritically used. What do I mean by critical use? You choose them wisely, you apply them critically, and you change them or edit or adapt them in case they are not fit to your specific use case or context. Examine one way of doing that is to see how it has been used in literature, but be careful because there are a lot of papers out there which have merely used these frameworks because they sound very technical. So very often I hear people saying, okay, I did this study. Now they want me to have a framework in it. So then what can I use? And then you quickly see, maybe this seems like a framework, and then you force fit some framework into your study after the study is done. This will make it completely unscientific and also, very poor in terms of what you will get out of it. Frameworks are not an end to themselves, they are a means to an end. If the framework is helping you better design your intervention or better analyze your intervention, then use it. If it is not, then maybe you should re-examine whether you need a framework or not. And finally, framework is a lens. And purposely, I've chosen this cartoon of Kekule, who supposedly saw benzene through some kind of a serendipitous act of a snake biting its own tail. And apparently, he then thought, oh, this may be how the benzene model is. So beware. If you look at the world with one framework, then the entire world can be explained by that framework. So frameworks have that kind of a huge limitation that they become all explanatory. So that's the reason we have to be very careful if we are overfitting the world to a specific framework. This is also something epidemiologists will tell you on fitting data to models. It's really the underlying scientific principle on fitting data to models versus fitting model to data is very similarly transposable to social science work also, where we have to be careful on whether we are fitting our data to just a framework or we are using the framework to make better meaning from the data. With that, I'm very happy to have interaction and and in case if I have misspoke or if there's any disagreements or different ways in which participants would like to share about that, I pass back to Dr. Ganesh to facilitate the next portion. Thank you.
Thank you, Dr. Prashanth. That's really insightful and also gives a kind of like a direction to think on what actually these frameworks mean on implementation research and how we need to consider them carefully based on the context where we are going to investigate, particular from the societal perspective. So I could understand that uh, the the sociological mechanism involved in the health system, and as well as how these frameworks should be carefully chosen when we are approaching it with a specific implementation research question. We have some questions, and I will also uh, hold some of the questions from mine on observing your frameworks, on choosing the frameworks on that. One, Dr. Abraham has asked a question that is it okay to combine frameworks to make them more comprehensive? Is it not advisable to combine multiple frameworks? If I understood correctly, he is trying to ask, can we combine multiple frameworks for
In
the
the same
same
study.
kind of like an question? Yeah.
Study, yeah, I wouldn't actually, of course. So please, when you are asking me a question, I would like you to consider me as a peer who is also struggling with theories and frameworks. I wouldn't speak for the entire discipline. So also take my advice critically. I personally would not use more than one framework in a study unless there is a strong case to be made. Uh, I can give you an example. Let's say for designing an intervention with communities, you might want to use a certain framework. So, but maybe for analyzing your data, you want to have a different lens. I can see in this scenario a case that can be made by you to use two very different frameworks because the purpose is very different. Like was what I was saying, the CFIR is a very interesting example of a framework that is often overused. I feel, everyone would like to because it's also very popular and there's nothing wrong with the framework at all. But it is not a framework that can help you with evaluation of your intervention. It's not a framework, for example, that can help you with looking at the process through which change occurred in your intervention. What it helps is in design, right? So it tells you that if you're designing your intervention, be aware of so many different levels at which you have to think through. Have I thought through the elements in my inner setting and my outer setting when I design this intervention? It helps you with formative research, for example, to be able to take into account various components that will have an impact on your intervention, but it may not help you if you want to create a theory of change for your intervention, or if you want to make an implementation model of your intervention, it may not help. So you can think, or to summarize my response, you can use more than one, but do so with a clear understanding of why you are using more than one framework.
Thanks for that. Just in line with the same kind of a discussion and the thought process, I was trying to relate it to two, three things. Uh, are there any kind of like an see, because some of the frameworks are for evaluation, some of the frameworks are for process, and some of the frameworks are for say like formative part of it.
Mhm.
So and some of the frameworks covers both also like both process and as well as evaluation, and some are both formative and as well as processes. Are there any kind of like an say like a decision tree tool someone has envisaged in selecting these frameworks? Of course, at the inception stage, one thing which you carefully and critically mentioned is that we try to fit in the framework at the end of the investigation, or at the or post the study we wanted to fit the framework, and that kind of like an urge happens in order to increase their probability of publishing it in
Publishing,
implementation
yeah.
research journals. I'm talking from the mind of a typical researcher who wants to really pursue on it. And as IR, we are in a nascent stage. So, are there any kind of like an decision tree, or a kind of like a checklist, or somewhere as like kind of helping tool or a guidelines with in what kind of like my implementation research question that this framework, or these are the list of frameworks where we can go through it and decide whichever is fitting to your context for that.
I'm quickly looking at there is actually, and I don't get. I think it's Nielsen's paper. I think
Exactly. Yeah, there is.
which tries to look at this. Yeah, Nielsen 2015, making sense of implementation theories, models, and frameworks. It's an attempt at trying to do so, but I must warn that merely because there are these kind of papers out there
mm, mm,
which do this, we should not imagine that this is a settled truth, because
mm.
we have to look at the also the nature of production of knowledge in global health, what is called as global health. So
Mm,
typically a lot of these are coming from universities in the United States, UK, Europe, because they have the power and access to try and do these kind of research in multiple countries. And there's a way in which they have been, I think there's nothing evil about it, but they have been able to dominate the whole publishing knowledge out there with
I hope you are there, Dr. Prashant.
sorry.
Sorry. Yeah, we lost in between. Sorry.
Okay,
Okay.
okay. I was just saying that it's time that people like us, now ICMR, for example, has the National Health Research Priority Projects. NIE, for example, has so much of experience with operational research and implementation research. So we can also sometimes critically evaluate and develop our own way in which we feel, look, this is the way we went about analyzing. See, what is I think important is not to just brush them aside as, oh, these are American frameworks, so it is meaningless in India. I don't accept that. On the other hand, what I also do not often see as useful is to completely embrace them uncritically. So we can come up with our own ways in which we can look at building or conceptualizing frameworks for our own practice. I gave you the example of Adivasi health.
Yeah.
You can also look at urban poor neighborhoods. Many today in many Indian cities, even if there is free care available in government primary health centers, many people are not accessing it for various reasons. So it's not really a question of geography. So
Mm,
how do we then make urban primary health care accessible to urban poor neighborhoods and other communities in cities? A lot of these kind of questions allow us to look at frameworks that we can indigenously create. It's a nascent stage, so although Nielsen's paper, which you have helpfully posted in the chat,
yeah.
is useful,
Mm,
I think over the next decade, through the sheer number of IR studies that ICMR and other entities are doing in India, which are Indian led, we should try to collaborate and reach across institutions and create these kind of resources you are talking about, a kind of mapping of different frameworks that are useful in Indian settings, or a checklist of how to ensure that I have the fit for purpose framework for my intervention.
you correctly mentioned it. Interestingly, we have many questions that have been posted in the Q&A. One of the question is that could you point towards multiple ways of studying politics and its influence on health? It's generic question, but they mentioned that, for example, CFIR doesn't touch much on politics
Correct.
or the
Correct.
governance or leadership. Yeah.
Correct, correct. So I just to for the sake of terminology here again, I will understand politics to mean not electoral politics. I'm
Yeah.
stating the disclaimer because very often people confuse
Mhm.
in the context of public health or social science also. Politics is a
Politics.
term that indicates the way in which people, populations, agenda setting, and interests, power, hierarchies, and all of these interact and then create change. So seen in that context, relatively less engaged with the idea of social and political processes. To give you an example, how do we implement programs in a
Mm,
way that trust and dignity in care is enhanced? It's if 7 o'clock. If that is a question posed to many of us in real world settings, trust building for all different kinds of communities or preventing discrimination at the at the point of service delivery is an important social and political outcome that we'll have to think. And for this, we'll have to, if that becomes our question, for example, in some districts where I work, there are some communities that feel discriminated at the care point of service delivery. A lot of that may be unintentional. It may be because cultural competence of care delivery workers is poor. It may be because some social groups are underrepresented in healthcare delivery itself. So there might be an unconscious bias in the way care is delivered, which may cause people to feel discriminated. So whatever it may be. So based on this, if this is our conceptualization, then we can bring in frameworks which you can use social exclusion frameworks, you can use cultural safety and competency frameworks. So again, the point being that depending on the nature of your implementation question, we have to choose theories and frameworks that are fit for purpose. CFIR, if it is applied in all IR contexts, will be a disaster, I think, if we apply it uncritically.
Exactly. CFR is very popular among being used multiple ways. Somehow they are relating to the health system context of that. So one more question has been added in terms of that, like in what ways can we adopt or modify or create new frameworks? You answered it on line of that. That fits to our purpose better. For example, equity focus implementation. We have very limited frameworks. So the Dr. Shruti Bora has asked this question: how can we add to the literature of IR frameworks if we develop one thing? So what is the way that how we can add to that larger library of frameworks?
So here again, frankly, to be very honest, framework making and pushing is also a political process.
Yeah.
Right. So, and I think we should just claim that politics. I mean, why does a certain framework become popular? It becomes popular either because the WHO put it, and then if we go and ask who brought it to the WHO, that is political economy work. How did a framework enter the WHO? Who put it there? Who did the agenda setting? So in a similar way, if we say way in which the world operates. So in that sense, if we say, if a large number of institutions in India get together, right, and we hold a series of consultations based on multiple empirically validated researches conducted, which are equity focused. And let's say, I'm just making up, let's say ICMR NI holds such a consultation of people represented from different geographies and institutions. And the purpose would be to say what kind of a overarching equity-oriented implementation framework should we use in India? And if we publish it, and then if we start having webinars and talking about it, in 5 years, we will see this so-called India equity framework being used in literature. So what I want to lot of science also operates through consensus building and through this kind of political organization, and there's nothing wrong, and I feel we should do so. How would we do it? We would do it like exactly like I said. What we would do is we would say that what we would first choose, let's say, I don't know, 20 or 25 studies that have examined how equitable certain IR or certain programs have been. We would invite people from those studies to say what are all the common elements that have helped them in their analysis, and together see what's coming out in terms of a framework that can guide equitable implementation of programs, and that would be a way of doing so.
Yeah, actually you have given us an idea now. Thanks for that question and this particular answer. I'm really seriously thinking of doing a kind of like a technical consultation meeting and to discuss about say like on a specific issue, either it is like an NCD implementation research or an equity implement or a technology implementation research on digital health. What are the different frameworks, and we can discuss and present the papers. That's a wonderful idea.
Sorry. Sorry to interrupt you, Dr. Ganesh. Digital health, for example.
Yeah.
Digital health, I feel, begs for the field of digital health I feel begs for a more indigenized framework that can
Yes,
work in our settings. For
exactly.
example, Aadhaar, while it can be on one hand hailed as an important structural innovation, on the other
Mm.
hand, many of us know is also creating various exclusions. So, how do we then have some ways in which we can deal with it and use and mitigate those exclusions? What and these frameworks will not invariably be adapted to these kind of settings. So,
Mm.
very good example would be equity in digital health interventions. This is something multiple programs are today using digital health interventions. If you're a program and you're not using digital health, almost then
Almost, yeah.
you're a thing. So, how do we then look at a framework that examines equity
Equity.
or who you can use principles like human-centered design. So
Yeah,
who has been kept in mind as a typical
exactly.
user of a digital health intervention. So all of these are really powerful ways of doing it, and I hope many of us on the call will form
Will form. Yeah.
coalitions and groups and do so.
Sure, definitely. I think this we are actually having this entire email listing of all those people who are attending in that, and in future we are going to do that. And these are the people who are very serious on that particular topic. The another important question from Dr. Vendesh, he asked that in implementation research and framework utilization in the process, how far technological tools to assess them in successful, such as WenSim. I'm not sure about what's that WenSim. Some technological tools in terms of framework utilization or the processes. I'm not sure about WenSim and other things.
I didn't fully understand the question. I'm, of course, like I always do, Googling it when
Yeah,
SIM
yeah, even
is the modeling for
yeah,
causal loop analysis,
causal
etc.
loop analysis.
Ah, okay. So, causal loop analysis is, for example, another kind of an approach towards trying to build explanations for why programs or interventions are working or not working. Or do you can you read the question again? Sorry.
I'll just read the question again. In implementation, research, and framework utilization, uh, in the process, how far
Technology tools. Okay,
technological
okay.
tools to assess them?
I will share my own bias here.
Yeah,
For example, merely because SPSS adds a new feature, or
yeah.
if Python or R will have a new statistical package for doing a very complex calculation, does not make it more powerful unless we, the user, knows what meaning to make out of that output. The same applies in qualitative world also. In vivo, for example, is very
Mm.
often used for qualitative data analysis, but it's not like you feed in some data and you say analyze and then it will give you some analysis. I mean, many people do this with AI now, and it is
Yeah.
hugely promising, but I don't see that these are game changing for researchers.
For the
Um,
problems, health problems which we are facing, try to answer in
No,
research.
no. So
Exactly.
if you do not, if the research, I'll give you an example with qualitative analysis. Let's say you are evaluating, or let's say you are involved in an implementation research for a training for a package of interventions for common mental disorders in primary healthcare, right?
Mm.
And you have
Mm.
delivered the intervention. You're now doing some kind of a process tracing or a fidelity assessment or so,
Mm. Mm.
and you do focus group discussions with the patients, with caregivers, and focus group discussion with ashas and ANMs, etc. Together
Mm.
you will have created like some 70 or 80 focus group discussion transcripts, right?
Mm. Mm.
Now, unless you have some kind of a way on how I will make meaning from all of this, the
Mm.
availability of a software is
Mm.
not useful. In the case of NSIM, it appears to be a software that helps with causal loops, creating causal loops. So
Mm.
that basically helps us go from what did the intervention give, through what multiple causal steps,
Mm.
to the intended outcome, right?
Mm.
So in some sense, if you don't have some kind of conceptualizing as to what are the possible ways in which it might have worked, a priori you should have some kind of a conceptualizing, look for those, but also look for other ways which you did not hypothesize, which also came. Unless you do this, Vensim itself will not, for example, tell you what were the causal loops that went. So to summarize my response, all these technological tools are as good as the wielder of those tools.
I agree. Thanks for that. I will end with one final question. Can forming a community advisory panel involving multiple stakeholders, such as service users, service providers, private public providers, practitioners, and having a discussion with them will be helpful in order to choose these frameworks? Because these are the people who are not only the core researchers. I mean, this is out of the little bit of context where we have been discussing about the Indianized way, or we can say for our context, which is applicable for the potential research questions where we have for our Indian setting. So, can these people make a kind of like an stakeholders who could may not provide a direct answer or a direction towards frameworks preparation or selection, but they may provide an important insight? Is what actually broadly being asked. What's your comment on that?
Yeah, so two things. One is on community advisory board. Thank you for the person who raised this
Yeah.
question. Very often I see the mindsets of us researchers needs much more change than communities. But the reason I make this strong statement is advisory boards are treated in a very notional, symbolic way. We put them in grant applications, and then they are treated in a very, they're convened in a very convenience kind of way, and are also treated as, oh, these are after all lay people. What will they really know about hypertension care or self-harm or whatever it is, the favorite health problem you're studying? I think this is a huge lost opportunity, because advisory boards, if well created, will give will deal with what we called in the presentation the social complexity. Now, how do you deal with social complexity? You deal with it through diversity of experiences with that problem. Because I mean, whatever it may be, it be diabetes or mental health disorder or TB or anemia or maternal health, whatever it is impossible for that phenomenon to be well understood by one or a few group of trained researchers. Lot of these phenomena are completely seen differently by users, communities, health workers, elected representatives, SHG groups, etc. So a well-formed advisory group can become a powerful resource, can become powerful ambassadors for the work. They can really be game changers in community-based or IR kind of studies. Now, in terms of whether the advisory board should be involved in choosing the framework, I am less inclined there. I wouldn't discourage discussions around frameworks in advisory boards. I would try to use advisory boards to give researchers having a certain problem and knowing the problem differently from the way researchers know the problem. These are the ways I would say community advisory boards could work. But the key issue is, how do you empower advisory boards to not serve as a bunch of yes women or yes people to the researchers? So how do you ensure that the board has people who have sufficient ability to disagree if needed, or to contradict if needed the researcher? Often this is seen as inconvenience or inefficiency, but trust me from experience, this is not inconvenience or unnecessary. It actually enriches the likelihood of acceptance and consensus building and adaptation of the community based or implementation research that we do.
Thank you, Dr. Prashant. Basically, implementation research is more flexible, and as well as it doesn't fixated on some standards like a usual kind of like an quantitative research where we wanted to pinpoint, say, like in terms of RCT. Whereas an implementation research comes up with a kind of like an flexibility because it adopts more of the contextual aspect of it. So when frameworks come into an existence as an indigenous part of an implementation research, The major issue is that choosing it and as well as taking forward it. This is one start where we are trying to converse more about frameworks, more than to tell this is the framework. Policing, the one thing which I always like you whenever you say is that policing on frameworks,
Framework
policing on
policing.
theories has to be totally get away from that's there is no room in implementation research. It's flexible, it suits the context, and it is chosen by the group of people who decide on that. Wonderful discussing on that. I also expect more such kind of discussions happen. Thanks for the wonderful participants who had posted those questions and evoked these kind of discussions. I thank you a lot for joining this implementation research webinar series, and also to all the participants wanted to say that Dr. Prashanth is going to be part of the future ICMR IASC joint implementation research, a hybrid structured course we wanted to bring. And also, we also are going to reach out to all of you to be part of the implementation research discussion group. And we also want to have a technical consultation and love to host you all at Chennai, whoever could be able to make it, and also try to make it open in as an hybrid meeting. Whoever couldn't come also can join that. Thanks for joining, Dr. Prashant. Once again, I thank on behalf of ICMR and as well as behalf of IASC. Thanks for providing your wonderful time, and have a safe travel back and to your place. So to all the participants, we are going to continue our implementation research webinar series. Our next session is 8th session, which is on implementation research strategies and methods to document processes. You all will be receiving an email about the exact date and the time of this particular webinar. Dr. Rupak Mukhabdya is a Director of Research of Community Empowerment Lab. Thanks for joining. And again, we'll also be expecting these wonderful participants again in our next webinar session. Thank you everyone for joining us. Have a great evening. Bye.